The era of personalized medicine in metastatic cancer care has unequivocally arrived. Translating personalized medicine to practice for metastatic patients requires a clear diagnosis and a complete understanding of clinically relevant biomarkers. Pathology assessment of morphology and IHC does not always produce a single unambiguous tumor type and subtype, and IHC has been shown to be inaccurate in 1 out of 3 metastatic cases, particularly in poorly differentiated lesions. This uncertainty ranges from cancer of unknown or unclear primary, or CUP, to scenarios in which there are 2 or more possible diagnoses. One option in cases of unclear diagnosis is to utilize broad genomic sequencing to detect and treat genetic alterations with targeted therapies without regard to the site of origin. However, early results from basket trials have demonstrated that both the tumor type as well as genetic alterations are critical determinants of benefit from targeted treatments in metastatic cancer patients. Applying this learning to cancer of unknown or unclear primary origin, it becomes apparent that every effort must still be made to achieve a definitive diagnosis before considering targeted therapies based on detection of genetic alterations alone. For metastatic cancer patients with an unclear diagnosis, CancerTYPE ID is the most widely adopted test that helps physicians make an accurate diagnosis. CancerTYPE ID analyzes the differential expression of 92 genes to distinguish between 50 tumor types and subtypes. In a blinded validation study, CancerTYPE ID showed overall accuracy of 87%, even when there was very limited tissue. In a head-to-head study, CancerTYPE ID showed statistically superior accuracy compared to IHC in patients typically referred for a second diagnostic opinion. In this study, IHC showed a significant decrease in accuracy compared to CancerTYPE ID when more than 9 stains were required to establish a diagnosis. Importantly, for these patients, CancerTYPE ID is the only test that has demonstrated impact on clinical outcomes in a prospective study. In this trial, in patients with an initial diagnosis of cancer of unknown primary, CancerTYPE ID provided a primary tumor type and subtype in 98% of patients. Compared to a historical control of patients treated with empiric chemotherapy approaches, there was an increase in overall survival of 37% or 3.4 months with CancerTYPE ID-directed treatment. Finally, clinical utility studies have demonstrated the impact of CancerTYPE ID in real-world settings. In this environment, the tumor type identified by CancerTYPE ID was not considered prior to using the assay in 41% of cases, but the final diagnosis was modified to reflect the test result in 2/3 of these cases. Few additional diagnostic tests were ordered after CancerTYPE ID testing, suggesting that most oncologist respondents viewed the results of the assay as being definitive, and the test results informed a change in treatment decision in approximately half the patients. Backed by this evidence, CancerTYPE ID has emerged as the market leader among molecular cancer classifiers. In summary, CancerTYPE ID can help serve the needs of metastatic cancer patients with an unclear diagnosis and should be considered by physicians to eliminate a diagnosis of cancer of unknown primary as the second opinion of choice when pathological assessment fails to produce a single tumor type and subtype diagnosis based on the first round of IHC stains, to help differentiate between new primary and recurrent metastatic disease, when there is limited biopsy tissue available for diagnostic workup, and for patients with atypical presentations when the IHC and clinical presentations are discordant. Biotheranostics believes that every eligible patient should have access to CancerTYPE ID. For patients with private insurance, we offer a patient assistance program. CancerTYPE ID is 100% Medicare covered with no patient responsibility.